Today is on myopathy, and again, like the neuropathy talk, it's pitched at a slightly higher level, aimed at the general physician, basic physician trainees, but hopefully you can follow along. Okay, so we always talk about the opathies in these latter talks. Encephalopathy is brain disorder, myelopathy, spinal cord disorder. I repeat these things over and over so that you become very familiar with this terminology. Trust me, it'll help you later. Radiculopathy, nerve root disorder, plexopathy, plexus disorder, neuropathy, nerve disorder, which we discussed last week, and of course today is myopathy. More specifically, myopathy refers to any disease that primarily affects muscle structure, metabolism, or channels. The general approach, as always, is a history and examination, nerve conduction studies, and electromyography, or NCS-EMG, classifying the myopathy, and then doing blood tests and muscle imaging. It's similar to the neuropathy approach, except we do use muscle biopsies more in myopathy. And we'll return to the Galt exam. Once again, the most powerful examination in neurology and probably all of medicine. I won't go over it in detail again today. It's there from last week's talk. But again, when you do the Galt exam, there are 5 steps. The first step is observation or inspection. You want to observe the gait very carefully, preferably in a hallway. And there are 9 major gaits. We don't talk about musculoskeletal or orthopedic related gaits in this talk. But from a neurological perspective, there are 9 major gaits. And you've just got to try and figure out which one it is. If there's a neurological disorder there that's affecting the gait, it'll almost certainly be one of these 9. And of course, today we'll be talking about the myopathic gait, which is the one outlined in yellow. Now, the myopathic gait is also known as a waddling gait. You can see from the photo here that what happens is as the person walks, when they lift up one leg, the pelvis would normally stay parallel to the floor, but in a myopathic gait, because there's proximal weakness of the hip girdle muscles, that pelvis, when the leg is lifted up, will drop down to the floor. And so you get this kind of waddle. Every time the leg is lifted up, the pelvis drops to the floor on that side and vice versa, and they look like they're waddling as they go along. Sometimes the head, as you can see here, will also move over to compensate for the shift in balance. But to be honest, these waddling gaits are not that easy to identify. Often they're quite subtle, and I find it personally one of the more difficult gaits to spot diagnose. When it's severe, it's pretty easy. Step 2, always stand the patient with the feet together and then do a heel-toe walk, and this is a non-specific test of balance, so if it's abnormal, it suggests ataxia. Whether the ataxia is sensory or cerebellar, it doesn't tell you that. So it just tells you this person is ataxic. Why do this step if you have a myopathic gait? Just because in an examination setting you want to be complete and do all the steps. But it may not help you much in a myopathic gait because it's not actually a test for myopathy. Third point, do Romberg's test. Again, I prefer to do these with the feet apart. I don't see the point in making it very difficult for someone who's elderly, but some books like to do it with the feet together. You must be ready to catch the person when you do this test, and Romberg just differentiates between, if you have ataxia, a cerebellar and a sensory ataxia. So if Romberg's is positive, i.e. the patient will fall if you don't catch them, then that's positive, and that means it's a proprioceptive defect. Cerebellar defect should have a normal Romberg's. Step 4, stand the person on their toes and then their heels, and this is a test of distal power. So if they have difficulty standing on the toes, which is actually the balls of the feet, not the toes per se, it suggests weak ankle plantar flexion. And if they have difficulty standing on their heels, dorsiflexion is impaired. And in that case, you should have seen a foot drop or a steppage gait. You'd be thinking more along the lines of a neuropathy than a myopathy. This last step is very important for myopathy, the squat. So this is demonstrating in this photo, this picture here, how to properly do the squat. So you should demonstrate for the patient how to do it. And it's always good to have a chair under them if you think they may not be able to squat. You don't want them to squat down and be unable to get up, or even worse, fall into the floor. So if the person has difficulty squatting, and again, you have to tailor it for a number of factors, their muscle mass, their age, and so on, then it could be supportive of a myopathy diagnosis. Myopathy is generally the condition that gives you difficulty squatting more than any other. Okay, so that's a quick run through the gait exam. Again, I covered it a little more a week ago, and if you want to get good at that exam, which I highly recommend, then I would look at last week's talk as well as this week's talk to do that. Now, there is a more specific myopathy exam. If you saw a myopathic gait, waddling gait, then you could launch right into this exam. And I find this a very useful exam. So often myopathy can be a spot diagnosis. You walk in the room, you see a person, and it's quite clear that they have a myopathy just by looking at their facial features and so on. Or perhaps you have done a gait exam and then you didn't know what it was. You did a lower limb exam and you saw that there was wasting and weakness, but the reflexes and sensation were all normal. That could be consistent with myopathy, in which case you do the myopathy exam. The first step, I like to go top down with these more specific exams. So I start with the face. There are features of certain myopathies that you can look for. Premature baldness, hollow temples, bilateral ptosis, so a slight closure of the eyelids bilaterally. It's usually symmetrical, not always. They might have a horizontal looking smile and appear glum. That's just because of the weakness of the facial muscles. They might actually be trying to smile but be completely unable to. And of course, there will be weakness when they try to close their eyelashes. They might complain of getting soap in their eyes in the shower. They might have difficulty whistling. So this would be the typical appearance of a man with a certain form of myopathy. You can see that there's he's a relatively young man, premature baldness, hollow temples indicating wasting of the muscle, in the face, and a bilateral ptosis. If you look carefully, his eyes are both, presumably he's trying to open his eyes normally, and they're both sort of half closed. So if you don't think about it, you could miss that, but this points to a very specific type of myopathy, which we'll talk about later in the talk. This young lady, again, has a more obvious bilateral ptosis. It's slightly asymmetrical. I think the right eye is a little worse than the left. She has the horizontal smile. She could even be being asked to smile here. I have patients like this with the condition she has. You ask them to smile, and they just cannot. And that is how. So people think that they are depressed, that they're walking around sad all the time, and that's not the case necessarily. And if you ask her to close her eyes, she's unable to close her eyes. So I actually can't tell if she's being asked to open her eyes or close her eyes here. She might be trying to open them. She might be trying to close them. Then I proceed down to the neck. Often people with myopathy, because it affects not just the hip muscles, but also all proximal muscles usually, so the shoulder girdle and the neck muscles. So they might have their head just a bit dropped. It's difficult for them to hold their head up because their neck extensors are weak. And that's a very good sign just to see if they have a dropped head. And you can check neck flexion and extension as well. Moving down to the trunk, I had an old supervisor who told me there are two kinds of neurologists, ones that look at the front and ones that look at the front and back. And I've always remembered that. So this is where it's important, very important in an exam setting to look at the front and back, because the back will give you more information than the front for myopathy, often. But on the front, they do have a protuberant abdomen because their abdominal muscles are weak. They may have scoliosis if you look at the back, so their spine has an abnormal curvature. Scapular winging, outlined in yellow, a very important sign not to miss. And usually the medial border of one of the scapulae or both of them sticks out. And of course, there will be weakness. So there's one sign called Bivor's sign. If you ask them to lie in a bed and put their chin on their chest, then you see their belly button potentially move right up towards their chin. And that indicates that there's abdominal weakness. And often the lower abdominal muscles are afflicted more than the upper abdominal muscles. So the upper ones sort of pull the belly button up. You can also ask them to do a push up against the wall, or they might be too weak to do that. Just put their hands up against the wall, and that can often accentuate the scapular winging. So this young lady here has been asked to put her hands up against the wall, and you can see that the right medial scapula sticks right out compared to the left. That's a very good sign not to miss. So if you don't look at the back, it's impossible to get it. Limbs. So I go to limbs towards the end of the myopathy exam. Always look for wasting. right? Specifically look for wasting. If you don't look for it, you will probably miss it. And it should affect the shoulder and pelvic girdle muscles more, but it can affect distal muscles in some myopathies too. In terms of weakness, you want to focus on shoulder abduction and hip flexion. It's also good to check distal power. Again, some myopathies affect power distally, but make sure you check the proximal muscles very carefully. And there's a certain sign that can be useful in the limbs called percussion myotonia. There are certain myopathies that present with myotonia, which is a sort of a delayed relaxation of muscle. And you take a tendon hammer and you just tap the thenar eminence, basically the abductor pollicis brevis muscle in one hand. And the thumb should start to flex after that in a sort of a semi-contractile manner. And that's a good sign for a specific condition, particularly one called myotonic dystrophy, which we'll talk about soon. So percussion myotonia, it's fairly easy to do, always good to do if you do a myopathy exam, because if you find it positive, then it points to, the fact that you've probably got a myotonic dystrophy. Okay, nurse studies EMG. So we talked about these in perhaps a little more detail than you'd like last week, but the nerve conduction studies, of course, themselves are generally normal in a muscle disorder, right? So usually in myopathy, they're normal. But the EMG, the electromyography, which is where you put a needle into a muscle, basically any muscle, and you record all the muscle unit action potentials in the vicinity of the needle, that will often be abnormal. So there are three things to look for. We look for spontaneous activity. Again, normally in a lot of myopathies, there won't be spontaneous activity. Spontaneous activity means there's denervation, so some of the muscle cells don't have nerve attached to them, presumably because the nerve is dying, and that would be seen more in neuropathy. In myopathy, though, you can get it if there's inflammation of the muscle. So some myopathies have inflammation of the muscle, and they can give you these spontaneous discharges, fibrillations, positive sharp waves, the positive sharp waves deflected downwards. Otherwise, they're pretty much the same thing. Recruitment is the next thing you look at. So as a person increases the force of contraction, then more motor units, so that's a motor nerve plus all the muscle cells it connects to, more of those will be recruited to increase the power of the contraction. Now, again, with myopathy, because often the muscle cells are individually quite weak, you need more of them to contract sooner in order to get the power up. So you'll see this thing called early recruitment. Lots of muscle motor nerves and muscle cells get recruited early, and it'll look like the top picture there, where you get all these tiny little waveforms. Whereas a neuropathic pattern, you often have fewer motor units, but they're bigger because some of them have died and the other ones have compensated for them. And so you get these fewer, bigger compound muscle action potentials in the picture. Again, I'm trying to teach you sort of a year of training here in one slide, and don't worry about the details here too much. I'm just trying to give you extra detail for those who want it. The third thing is morphology. So looking at the shape of the motor units. In myopathy, we look for small amplitude, short duration, polyphasic units. That is suggestive of myopathy, like that top picture there. And the bottom picture would be more suggestive of a neuropathic pattern. Again, this is probably the most important slide of the talk. So myopathies, I prefer this way to classify them as acquired or hereditary. The acquired can go into three categories: inflammatory, endocrine, and drug-induced myopathies. The hereditary, four categories: myotonic dystrophies, muscular dystrophies, congenital myopathies, and then I lump the others together they're all quite rare into mitochondrial, metabolic, and channelopathies. The ones circled there are the ones we'll focus on when we do, in reality, and also certainly in the clinical examination setting. These are the myopathies you must know very well, because patients with these myopathies make excellent exam patients, because they're common and relatively long chronic conditions. Okay, so starting with the acquired ones. Again, we're focusing on myopathies in adults. So pediatric myopathies, there is, you see different ones, different degree, a different prevalence of myopathies, different kinds of patterns and so on in kids. We're going to be focusing on adults for this talk. So looking at the acquired ones, we're going to focus on the inflammatory ones. We'll devote a little bit of time to the other two, but there are three major ones: dermatomyositis, inclusion body myositis, or IBM, and polymyositis. Now, the inflammatory myopathies are a very heterogeneous group of disorders, so they can present very differently clinically. but they all share this thing called myositis, which basically means there's a degree of inflammation affecting some muscle somewhere. Dermatomyositis presents with a symmetric proximal muscle wasting and weakness, so very stereotyped myopathic pattern. They don't usually have problems with swallowing. They do often have a skin rash of some description. And what I've shown you here is two of the most common types. So the top one would be what you call a heliotrope rash. This is sort of reddish purplish rash, usually around the eyes. And then there's another one called Gauchon's papules, which are quite subtle and easy to miss, but they'll be on the knuckles of the hand. And you can see there that they are also slightly reddish in appearance. There's another good one called the Shawl sign, which affects usually the neck or upper chest or even the back, upper back. And that also presents with a sort of inflammatory looking rash. So these are quite distinctive. If you see these things, you probably, in the setting of a myopathic gait and pattern of weakness, dermatomyositis would be high on the list. Now, if you have dermatomyositis, it's often associated with a systemic disorder, so you want to screen for connective tissue diseases, other organs getting involved, like myocarditis. Remember, the heart is a muscle. Inflammatory lung disease, vasculitis, and cancer. So you would want to order appropriate tests to rule these things out too. This is a very interesting myopathy called sporadic inclusion body myositis, or IBM. And this is a little different from the dermatomyositis because it presents usually asymmetrically, and it targets certain muscles quite a lot, particularly the forearm flexors, the ones that flex the wrist, fingers, and the knee extensors. And very frequently, the ankle dorsiflexors are affected. Even though they're a distal muscle, it affects those ones quite a bit too. So you'll get wasting and weakness. This picture here shows obviously a very wasted vastus lateralis, rectus femoris. Basically, the quadriceps muscles are very wasted, as you can see, compared to the muscles below the knee, the calf muscles and tibialis anterior and so on, probably about as thick as the quadriceps, which is abnormal, isn't it? So that's clearly very wasted. And this is a very common finding you see in more advanced cases of IBM. They also often get swallowing difficulties, so dysphagia is very common. And a lot of people don't know this. It is the most common acquired myopathy in people over the age of 50. So it's uncommon, but not that uncommon. You do see these patients once in a while. Excellent exam patients. Third one is polymyositis. This is like dermatomyositis in that it is symmetric proximal muscle wasting and weakness. Dysphagia is also uncommon. And again, like dermatomyositis, it can be associated with these other things, so you need to screen. So dermatomyositis, polymyositis in an exam setting are fairly similar. One has a lot of rashes, the other does not. Otherwise, you're going to be having a very similar discussion with both cases. But IBM is quite different from both. Endocrine myopathies. These are many and varied. So I think the chance of getting one of these on the exam is quite low, but you'd want to look for signs of Cushing syndrome, a Cushingoid appearance as shown in the chart. That could indicate an adrenal myopathy. There are a few others there: thyroid, parathyroid, pituitary myopathy. Often we will screen for these with blood tests and so on, but rarely are they found. So I think it's good to know about them because you might see one once in a while, but they're pretty rare. And again, they generally produce symmetric proximal muscle wasting and weakness. So as long as you are aware that there's some kind of myopathic pattern there, you're on the right track. And you can just test for them. There are drug-induced myopathies. We do see these once in a while too. Certain drugs predispose to these more. So there's one called a steroid myopathy. That is fairly classic with long-term steroid use. The wasting may not be very marked. The EMG normally doesn't tell you much. Alcohol is another drug. Of course, alcohol affects a whole bunch of organs, as shown in this picture here. Don't drink more than a couple standard drinks a day if you can. My mom is Scottish, and she probably drinks more than that. In fact, I know she does, so she won't change her ways. So there may be coexisting cardiomyopathy, neuropathy, and other problems with the alcohol myopathy. Some of the classic drugs that give you a drug-induced myopathy are statins, colchicine, recreational drugs, such as these ones here, amphetamines, cocaine, and heroin. They can result in quite nasty, aggressive, even necrotizing myopathies. So it's really important to take a good history as to drug use, both medicinal and otherwise, when you see someone with a myopathy. And in general, all these things give you a symmetric proximal muscle wasting and weakness. Okay, so that's the acquired myopathies. The second major category, the other major category, is the hereditary myopathies in adults. So just to refresh your memory, there are 4 categories. The myotonic dystrophies on the left here are very common relative to the other ones, but the muscular dystrophies are not far behind. And then you've got, all the ones in blue are much rarer ones. So we'll talk about the ones in red to reasonable detail because these are the more important ones to know about. Myotonic dystrophy. These are an inherited group of disorders characterized by myotonia, which, as I said, is a delayed relaxation of a muscle after a voluntary contraction. And they have a phenotype that is not restricted to just the skeletal muscle itself. So often these patients will present with a mild degree of intellectual impairment, cardiac conduction defects, cataracts, the frontal balding, which I mentioned, and so on. And the most common type is type 1, also known as Steinert disease. And this fellow that we looked at earlier has that. So facial and distal muscle wasting and weakness will be apparent. So it's type 1 is unusual for a myopathic pattern in that it goes for distal weakness more than proximal. So that can make it tricky. But other than that, it's fairly easy. It's autosomal dominant. The affected gene is there. If you want to sound very smart when you are in the discussion after the exam. The second type, the second most common type is proximal, is type 2 myotonic dystrophy, and that results in a more classic proximal, but also distal muscle wasting and weakness pattern. It's clinically milder. They can get more muscle pain, and it has a different gene associated with it. Now, with these type 1 and type 2, but particularly the type 1 myotonic dystrophies, they're very good exam patients, and really it's essential to spot diagnose them when you walk in the room. So if you can't spot diagnose this, it could turn into a very difficult exam. So this guy, if you walked into a room and you're asked to examine this patient, you would notice that there's a relatively young man, frontal balding. He might have some wasting of his jaw muscles and temples. He might have the horizontal smile there. It's difficult to say. The ptosis is not particularly marked. Maybe the left eye is a little bit tosed, and he's obviously quite a thin guy in general. This lady, you can see there's a clear bilateral ptosis. For a woman, there might be a little bit of frontal balding. The ptosis is a little asymmetric. It looks like she's got some wasting around the muscles of the mouth. She might even be trying to smile, or maybe she has difficulty even closing it. Okay, so that is a young woman with type 1 myotonic dystrophy as well. And this is an entire family, because it is hereditary. With type 1 myotonic dystrophy, you can see a lot of the common facial features present there too. So after you see 1 or 2 patients of these, and we'll almost assuredly see 1 or 2 when we do the training later in the year, you'll be comfortable with this. And once you diagnose this as a spot diagnosis, the examination becomes quite easy, and it's more of a show. Okay, muscular dystrophies are also important to know. So these are an inherited group of disorders, most of which have genes identified and attached to them, but not all of them. And they're characterized by progressive muscle wasting and weakness and heart abnormalities as well. There are 6 major categories, and we'll just go through them quickly. So Becker dystrophy is symmetric proximal muscle wasting and weakness. It's X-linked recessive. The second one is Emery-Dreifuss dystrophy. You get a lot of scapular winging with this one usually, and the tibialis anterior muscles are affected. So you can see the circles there. This man here has Emery-Dreifuss. The circles there are showing heavily affected regions. The most common of these muscular dystrophies is the limb girdle dystrophy, and this is quite a varied category. So again, it's mostly symmetric proximal muscle wasting and weakness. They can get some distal components involved as well. It's mostly autosomal recessive, but it's diverse genetically, and If you think you have a muscular dystrophy, but you're not sure which one, if you guess limb girdle, you probably will be right because it's the most common. This young lady, whose picture we saw before, has one called facioscapulohumeral, or FSH dystrophy. So this is a particular dystrophy that you see once in a while that likes to go for the muscles of the face, gives you scapular winging, and of course the classic symmetric proximal pattern. So this lady obviously has a quite marked affectation of the eye muscles and the muscles around the mouth. And this is a very classic appearance, I must say, for a person with FSH dystrophy. So again, this is another spot diagnosis. You should be able to spot diagnose this one usually. The spot diagnosis is so key because it means you can launch right into a gait exam, which you may have been asked to do, and then you can launch right into a myopathy exam. And you can do all that very quickly, and then you can do some extra stuff just to show that you can, you're doing extra, and you should be able to do very well that way. There are distal muscular dystrophies. These are pretty darn rare. I don't see these very often. And symmetric distal muscle wasting and weakness, but they can also develop proximal muscle wasting and weakness. Like I said, it's very rare. Oculopharyngeal dystrophy. This is rare, but not as rare. I don't think I've seen a few of these. These people present with a bilateral ptosis and swallowing problems, and they get facial and proximal muscle wasting and weakness. So they get extraocular muscle weakness and ptosis. As you can see there, is quite a marked asymmetric ptosis. Noticeably, the facial muscles here may not be as involved as the young lady with the FSH dystrophy. So this also can be very easy to identify if you're looking for it. Okay, so summarizing those muscular dystrophies, so not the myotonic dystrophies, the muscular ones. This is a good slide if you want to have just a quick view of them. So the first one there is the Becker dystrophy. Emery-Dreifuss gives you this pattern. Limb girdle gives you the more classic symmetric proximal muscle and hip wasting pattern. FSH dystrophy loves to go for the face. Distal dystrophy, distal limbs. Oculopharyngeal dystrophy likes to go for the eyes, not so much the mouth. And it gives you otherwise the classic proximal muscle wasting and weakness pattern. So this is a very useful chart just to give you a sort of a bird's eye view of the muscular dystrophies. Congenital myopathies, this is seen more often in a pediatric setting in children. They're classified on the basis of histology. So they'll have a slow course of the classic sort of myopathic wasting and weakness, and usually in a kid. These two here, the Nemelin myopathy and centronuclear myopathies, can be seen in adults from time to time, but these are very rare, and there's no way you can diagnose them on an examination. By definition, you need to do some histology. And then there's the last category, very diverse group of disorders and very rare in adults. And there are three categories I'll talk about. So the first is the mitochondrial myopathies. They present with a quite varied phenotype depending on which one you have. The heart is often involved, and they'll have the eyes often involved. One called MELAS, or mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes, is exactly as it says, associated with all those features. These people can even present with multiple strokes before they're finally diagnosed, or multiple stroke-like episodes, I should say. There's another one called MRF, or myoclonic epilepsy and ragged red fibers. There's a KSS, or Kearns-Sayre syndrome, and CPEO, chronic progressive external ophthalmoplegia. I'm not sure how useful it is to know all these different illustrious words and descriptions, but just know that there are certain mitochondrial myopathies. If you have what looks like a very strange and complex myopathy in a young person, then it's worth thinking about these things. There are metabolic myopathies too, which on history present with episodic weakness and myalgia induced by exercise. So these ones are strongly associated with exercise. Again, these are seen much more in children, but you can see them in adults. I guess the CPT deficiencies I probably see once in a blue moon. Otherwise, these are extremely rare. And then there are channelopathies. So the muscle cell channels can present with, again, episodic weakness, which is maybe related to exercise, and that it's delayed onset after the exercise, but it may not be related at all to exercise. And they are often induced by other triggers, including heat, cold, diet, and stress. So I've listed them there. These are, again, extremely rare. I just include them for comprehensiveness, but you're not going to run into this in a clinical exam. At least I hope you don't. Okay, so when I encounter what I think on history and clinical examination is a myopathy, these are the blood tests I order. So my standard myopathy screen, you can just go to the slide and order these tests. Of course, you want a creatine kinase or a CK. That's probably your most useful test. It's usually elevated, though not always. You want to get electrolytes, liver function tests, thyroid hormone status, C-reactive protein. And I do order HIV. Often HIV is, it's a good thing not to miss. It can trigger a myositis, and HIV makes a lot of other disorders more likely and worse. Then, depending on the clinical history and examination findings, I will order more tests. So if I think there's an inflammatory myopathy, I might do a myositis panel. If I think there's a myotonic dystrophy, I'll do some gene testing. Muscular dystrophy, same thing, different genes though. And if there's a mitochondrial myopathy, you can do some targeted genetic testing too. So you don't order these ones willy-nilly. You need a good indication to do it, but they can be useful. Now, muscle imaging is very useful. So remember, nerve conduction in muscle studies are different from imaging in that they measure nerve and muscle function, right? So it's like looking at the engine of a car, how it's running. Whereas when you do an MRI or a CT of some body part, you're looking more at the chassis of a car. And you can have a nice looking chassis, but a bad engine. So, the MRI looks okay, but there's clearly a problem. Or you can have a bad engine and a nice looking chassis, right? So the nerve conduction study, EMG, shows major problems, but on the scan, it doesn't look so bad. So it's good to have both tests, but they're different. So with myopathy, we can do muscle imaging to look at the chassis. And some myopathies, that's important. So it can help you determine if there's a myopathy present, if you're not sure clinically, and also the pattern, which exact muscles are involved. You can do volume-based analyses. So this is one way of doing it here. This is the lower limbs where the muscles in the leg have been outlined by the radiologist in green in an effort to calculate surface area and do a sort of volume-based analysis that way by looking at multiple surface areas down the course of each leg. And if you want to do a muscle biopsy, imaging, MRI imaging MRI is very good for selecting the best muscle with which to do that. So this particular patient here on the right actually has inclusion body myositis, and I don't know if you can appreciate it, but probably the quadriceps, which are just above the bones there, are extremely wasted. Although most of the muscles are quite wasted, the quadriceps are probably getting it harder than the rest of them. Okay, muscle biopsies. So unlike nerve biopsies, which are rarely needed, muscle biopsies we do more. And the reason is, first of all, they're often more diagnostically useful, but also the adverse effect profile is much kinder. So muscle can obviously regenerate to a greater degree than nerve, and muscles tend to be a lot bigger, so you don't have the same difficulty if you take a tiny bit of a quadriceps muscle. It's not like taking a tiny bit of a sural nerve, which could be a lot of the sural nerve. So there are adverse effects. You don't order these too lightly, but they can be very useful if you need the diagnosis. And the best muscle to order them on is not a super wasted one, but not a normal one. Obviously, you want a muscle that's moderately wasted. The best ones are usually deltoid, biceps brachii, and the vastus lateralis muscles in the lower limb. All right, so to conclude this talk, the gait and myopathy examinations are very useful when you have what you think may be a myopathy. Nerve conduction studies are usually normal. If you are asked what the EMG might show, just say it'll probably have small amplitude, short duration, polyphasic units. That's it. In proximal muscles, more than distal. And make sure you know particularly well for an exam setting, the inflammatory myopathies, the myotonic dystrophies, and the muscular dystrophies. Those three are very common exam patients. And you'll see them as patients as well pop up once in a while too. Okay, so that, my friends, is myopathy. Thank you very much.